What I hope to do for you today in this first talk is just to take you into an area that I think is very exciting in terms of where radiology is going as we shift into two areas. One is into intervention and the other into functional imaging. And this talk will focus on some of the developments in interventional. I want to acknowledge my colleague, Dr. Rob Su, who dragged me kicking and screaming into RF ablation in the lung and who really heads and runs our program. As we all know, radiofrequency ablation is the controlled application of a high energy source, and it is thought that the thermal ablation is very effective in destroying primarily the cancer cell that the lesion is targeted, as well as some adjacent tissue, and it's a well-established technique in many parts of the body today. What I'm going to do today is focus on some of the work going on in the lung, which is an area that is kind of an area like everything is today, fusion between research, but clearly an increasing area. The preceding talk was an excellent talk of lung cancer detection and nodule detection, and with that we're seeing a high incidence in these nodules. Biopsies are being done on smaller and smaller lesions, and there's a need for those of us in radiology to really focus on how we can take intervention that may clean up some of these algorithms rather than surgical pathways that may or may not be more invasive down the line. So what I'm going to do for you is give you a fairly practical overview of the process. Let's start with the patient selection criteria. We started off looking at patients who had primary and or secondary intrathoracic neoplasms. This included both pulmonary, mediastinal, and pleural chest wall. They needed to be primarily solitary, but we did take on multiple lesions, either doing two at the same setting or repeated techniques. Less than 5 centimeters in the largest dimension is how we've started, because that seems to be the size of needle to tumor ratio is important, as we'll see. The lesion had to be accessible via percutaneous transthoracic technique, and it needed to be non-contiguous with vital structures, which unfortunately in the chest there are many. We also were very careful in this initial phase to take patients who were essentially refractory or were not eligible for other conventional therapeutic pathways. We also looked at patients who required local treatment for pain, etc., that we felt may be amenable. These are the kind of patients that might have gone to radiation, that we felt that RFA may in fact play a role. We also looked at unresectable lesions. And unresectable, of course, is determined by two things: not only the actual characteristics of the lesion, but the patient morphology as a whole, whether they are surgical candidates based on their pulmonary function. We really were, as always in interventional radiology, you pick up the cases that nobody really wants to treat. So you start off with the sickest and the most complicated cases, when really our whole goal is to try and see whether this technique will work as a primary pathway for some of those early lesions. But that's how we started, and that's currently still the algorithms that are in place and are certainly part of the trials that are going on at the moment. Very important aspect here is that in the surgical management, there is an approach to really try and identify whether there's mediastinal lymphadenopathy. And obviously the mediastinoscopy is a very important part of the procedure that we can't really do in the imaging world. And so we find it important to exclude intrathoracic lymph nodes as well as nodes in the base of neck, and this is done using CT and PET, and sometimes we send cases to mediastinoscopy to make sure that we were not dealing with patients who were already known to have regional metastatic disease. Exclusion criteria, as you might expect: inaccessible lesions, high-risk areas, and abnormal laboratory work, primarily clotting profiles. Just a little review on the RFA procedure. Pre-procedure requires a good consultation between the radiologist performing the procedure and the patient. This is not a minor intervention. In fact, as I'll show you images, the first couple of cases I felt were fairly aggressive in their side effects within the lung, but it turns out that in fact the lung is an amazing organ and tolerates the procedure extremely well. But nevertheless, these are one-on-one consultations with the patient. You have to make sure that there's a good clinical history, that you've gone through your characteristic pre-workup, as you would do for any interventional procedure. And we have a scheduling service that we market every time we show it. We also have some intra-procedural considerations. We try and do these things on an outpatient basis. If this is to have a place in the management, we feel it should be outpatient-based. You obviously have to have good monitoring during the procedure. There's a big debate as to whether these should be done under conscious sedation or under general anesthesia. We have taken the route of conscious sedation and as well, of course, local anesthesia. The application of the grounding pads, you need to obviously have a good CT scanner, preferably now something with fluoroscopy, but not required. All of the procedures done to date have been done without fluoroscopy at our institution, and we use a classic tandem needle technique. And then very importantly is a post-procedural assessment of these patients. There needs to be a mechanism in place, as you would have in any interventional suite, for these patients to be monitored. They have at least a limited time with us in the suite. We try and do the procedures in the morning. They stay with us through the afternoon, and they leave by about 6, 7 o'clock in the evening, or we may admit them overnight for a limited stay. And what we look for is for the fact that before a patient leaves, they should only have acceptable side effects, such as reasonable discomfort, which is managed by conscious sedation initially, and then by oral analgesia by time of discharge. There are complications that can occur from the procedure, and if we break them down, the first is from the RF electroplate itself. You can get prolonged pain, as my colleague published in Radiology in 2003. Then locally from where the needle is placed, hemoptysis and hemorrhage and hemothorax are obviously things you're concerned about, and when you look at the size of the needle going into the lung, you are amazed that this is not a bigger problem. And then, as any intervention, infection, pneumonia, and abscess down the line, and pneumothorax that we'll talk about in a moment, because in fact there's always an intraprocedural pneumothorax, a significant pneumothorax being one that requires drainage by the time the patient would normally be discharged. Just from the RF energy, we've observed that there's a whole syndrome that's attached. This has been well described in the use of RF ablation in the liver with colon metastases, the post-ablation syndrome, or some fever and malaise. You have to be careful. The energy burns can be quite painful, and this is something that needs to be observed during the procedure. And one of the things you always need to remember with RF ablation techniques is if there are medical devices that are electrophysiologic in action, there can be disturbance between the two. Conscious sedation, we use a high dose of conscious sedation. We do not use full general anesthesia, but as a result, we are very conscious of the fact that the more drugs you give, the more likelihood you have nausea and vomiting. Aspiration ARDS is obviously a concern, and so we try not to do these procedures on anybody who has eaten the last 6 to 8 hours. Arrhythmias from drug interactions. There's, of course, potentially radiation related, although that's not been seen. And then there's the tumor necrosis syndrome, which is very similar, in fact, to the RF malaise fever type syndrome. The application of RF, just to go through a couple of the needles that you can use, the FDA has approved several needles for the deposition of high energy, not necessarily for an application, but just for the concept of placing them within a tumor or an individual. And there's a wide range of manufacturers, Radionics, Radiotherapeutics, and Rita all make needles. Some have a cool tip system. They all have different generator morphologies. And so a typical type of setup looks like this. And you see the generator box and the different needles as we place them in. And here you see the kind of needles that we're using. These are needles that are really designed for the liver and have not been modified dramatically. There has been some modification over the last few years, and these, in fact, are the latest needles that we are using. And we favor the ones with the multiple tines for reasons I'll show you in a moment. And diagrammatically, of course, the reason is that what you want to do is place the needle in the lesion so that the tines have a nice radial relationship, and you are at the tip of the lesion, and you're looking for this burn effect on the outside. There are a couple of standardization approaches that are very important so that you make sure that when you're doing the procedure, you think you've achieved a good burn. And so there is a couple of standardized approaches that have been brought together by the different research collaborations and published by Goldberg in 2003. We look for the necrosis of coagulative effects, the coagulation necrosis area, the ablation zone of the lesion itself, and then the ablative margin. And this, I have to tell you, is one of the difficult areas in the lung. In the liver and in other soft tissues, a lot of these techniques can be performed under ultrasound or under MR. Tissue characterization is well done, and you can see the direct effect of burn, and you want to make sure that there's a ½ centimeter ring of adjacent zone involved so that you think you've got a good burn. In the lung, we don't have that kind of tissue that we're dealing with. And so what you look for is a ground glass halo to develop around the lesion, and we believe that that's the equivalent, although it's never been shown in animal models. So here you see the lesions we take on. We are taking on lesions that range in size from 8 to 10 millimeter through, as I mentioned, to 5 centimeters. And what's important is that you place the tines at the rim of the lesion and do your burn. And this is the ground glass halo that we like to see immediately post-procedure. And here's another case that we'll come back to in a moment, a case that we've come through double tandem technique, patient on their stomach, and the needle is placed in. The tines show a good position, and you really have to make sure that you ablate the whole lesion. And the bigger the lesion, the more you have to reposition the needle and do multiple approaches into the lesion. You need to make sure that the tines reach the margin of the tumor, and that's why there is a size limitation. Let's talk a little bit about the limitations of radiofrequency heat deposition. It's the energy that's so critical getting to the 100-degree burn. One of which is patient factors. You know, anything in the lung is always, I believe, much more complicated than anywhere else. Maybe a small bias. But the ability to cooperate and breath hold is critical, yet you want good conscious sedation on the other side. And that balance between good conscious sedation and the cooperative patient is why many groups have taken to doing full general anesthesia. There's also sometimes these patients who have malignancies, you have clotting profile issues that you cannot rectify, and we will not undertake a procedure that there is any question about that. Lesion factors are location. The hilar and mediastinum are always problems for interventional procedures in the thorax. Contiguity with the vital structures has a problem, not just because of the potential damage to the adjacent structure, and that's of course a concern, but also the heat sink effect. You've got a very good blood supply. The last thing you want to do is have your high energy burn being generated and blood flushing it away so that it cools down. And so that's a big issue in terms of lesion position. Lesion texture is also an issue. There are some really hard lesions that are very hard to get the needle into, and we haven't quite got to a good feeling as to what determines that, but the texture of the lesion is important. So here you see a case that we took on. Here's the lesion. And the nice thing about working with a very aggressive colleague is that we had to prove that these things were difficult, and we placed the needle into the lesion. And what you see is that, in fact, after we've tried to do a burn, there is no halo to be seen. The lesion looks not very different, and no real damage, thankfully, done to the adjacent structure. This is a heat sink effect. In addition, there is another problem with limitation with radiofrequency ablation. You can only really treat one tumor at a time in a region. And so here you see a case that we took on. This had a couple of other issues for us. It was situated, again, next to two very big vessels. You obviously want to place your needle carefully, but more concern is the heat sink effect from the adjacent blood structures. Good deployment of the needle was achieved, and we thought we'd done a really good job with the burn when a new nodule cropped up just the adjacent section. And so this is part of the issue as to how we decide when and how to do these procedures. A big issue has in fact been the follow-up of these lesions. Again, the problem in the lung is we're never quite sure whether we have achieved a good burn. We have an indirect sign of the ground glass halo. The second thing that we can do is try and see whether we destroyed the lesion, and conventionally as diagnostic radiologists we're all used to the concept of measuring lesions. Well, the catch here, as you'll see, is that nothing gets smaller after RF ablation. The lesion area appears to get bigger. And so for that reason, there's been a lot of discussion in the development of some of the multi-center studies, as well as the deployment of this technique into clinical practice. How do you know that you got a successful burn at your first treatment? Because if you don't think you did, you may want to go back and do a second one earlier rather than later. And as we already saw in the preceding discussion, CT has one way of looking at this, and that's to look at the blood supply to a lesion. And densitometry, the Swenson approach, was modified and used in trying to see whether the contrast uptake profiles changed. Another way was to obviously have to do a multifocal CT looking for metastatic lesions, And then you have to also think about the fact that maybe PET has a role here, as we saw in the workup of the primary nodule. So we think that there's a role for PET in the activity of the lesion post the burn, and we'll have a look at some of those techniques. I won't go into the nodule densitometry because it was so nicely done in the preceding talk. We've modified that technique just a little bit to shorten it just a touch. We give 100 cc's of Omnipaque. We scan at 0, 45, 90, 180, and 300, and use the same 15 Hounsfield unit threshold, although we too are now looking at moving to the perfusion techniques that may be more sensitive. And here's the kind of thing you see. Here is a lesion that is being followed, and here you see the contrast uptake over time to 300 seconds. And here's another example of a case. So pre-RFA, the lesion had a good enhancement profile, as you'd expect for a primary lung lesion. It increased by 88 Hounsfield units. Obviously, no procedure is done without tissue confirmation. So in fact, a very important part of our process is an initial needle biopsy. We will not undertake at this stage RF ablation without that. And then post-RFA, here's the burn site. And you already get a glimmer that in fact the area involved is a little bit bigger than the original lesion. But what you see is that pre and post contrast, the uptake profile is very much the same and not dramatically high. A little bit higher than the 15, but looks very much as though there is no real uptake compared to the 58 preceding. So it's the delta compared to the pre-treatment that's been reduced that we feel is an important indicator rather than just an absolute number. And here is the kind of visual impression you get. I have to tell you that the very first case we did, we scanned the patient the very next day. And I have to recommend very strongly that you never do that. Because if you do that, what you will see is a complete whiteout of the lung, huge collections, and you will be tempted to do as I did, feeling that I had misled my then junior colleague, now very much my equal colleague, in getting him to do RF ablation, and that he had led me up the garden path because this patient would never recover. There were huge collections and diffuse whiteout. We put in chest tubes. We watched the patient through the weekend. Of course, he had gone away for the weekend, and so I was managing the case with a fellow at the time. I was almost expecting to call thoracic surgery at any moment. He returned on the Monday and said, take the tubes out, it'll be just fine. And that, in fact, is exactly the case. Do not image these patients unless there's a need to do. Obviously, when patients come back with pain or complications, we do it, but we did have a very aggressive early surveillance. We dropped that, and the earliest we want to see the case is at 1 month. And so here you see the baseline. This was the lesion we treated, had an uptake of 35 Hounsfield units at the time of diagnosis. Needle confirmation of the pathology was confirmed. Here is 1 month later, and this is why size criteria go out the window. There's no way that you can now use a measurement of size as a way of deciding whether it's better or not. Here you see, as we often do see, a small loculated collection adjacent, and then obviously, as you see over the course of time, the lesion scars down, and we have initially no uptake of contrast in this area. Not surprising, because you've probably resulted in a fair degree of damage to the surrounding vessels, and so there's no uptake. And then over the course of time, we saw that there was a slow return of Hounsfield unit uptake. We then got up to about 26, and we were worried that in fact there was residual tumor here. At 15 months, however, this was back down to 15, and this patient is now 3 years out and has shown no change from that moment. This is just another slide to make the point of some of our initial subjects from the paper in 2003, that size and contrast uptake are not very useful. What I'm going to do is take you to an actual case that make the point. So here you see size of lesions, patient A in red. Here was the size of the lesion. It appears to get much bigger and then get smaller over time. There was another case in which the lesion appeared to get smaller and then get bigger over time. But when we looked at the profile of contrast enhancement, in fact, we got a very different picture. It was quite clear that although this lesion was decreasing in size and was still much smaller than baseline, there was a rapid increase in attenuation, and this was a failed treatment. So it's very important in the follow-up of these cases that you do both a structural and functional analysis. Again, there's been an attempt to standardize the reporting of this, and this is what we do at the moment. We try and report on the coagulation zone, the ablative zone, the margin, and then on the difference in enhancement pattern pre and post-treatment. The other issue that we can start looking at is, and here's another case we can quickly look at. Here's a lesion that we took on. Again, this was a case that just about met our criteria for doing. There was some discussion as to whether this was the lesion. This was a small reactive lymph node, was the hope at the time. Needle was placed in with good placement of the tines. And then when we followed the lesion up, we found that at about 1 month, the lesion looked a lot bigger, but we didn't really have much contrast. But then you see what happened is that, in fact, there was a nubbin of tissue on the opposite side of the vessel. Again, a heat sink effect, and this is the kind of lesion that we now would not take on. The final way that we've started looking at these cases is, in fact, with PET. The hope here actually is that PET will guide the placement of the needle. What we're hoping to do on the combined PET-CT scanners is identify where the hot focus is, just burn that focus in the bigger lesions, and so limit the procedure time. But one of the things we've been trying to look at is the uptake. Here is a case that we took on. Again, a fairly central lesion, but thought to be distant away from vital structures for us. We placed the lesion. Here's the intra-procedural pneumothorax, which occurs at all times. At the end of the procedure, when we withdraw the needles, we make sure that we evacuate the air. And that's a very important part of the procedures, to make sure that you have evacuated that air at the end. And then here you see that when we give contrast uptake, we're following this lesion, this area. And here you can see that initially there was uptake in the area with PET, and 6 months later, that lesion is about the same size, maybe a little bit bigger, but stable in size, but very, very hot on PET. Another failed burn in this case. What about the literature? There's been a fair number of papers to date. A summary to date of about 17 patients has only really hit the literature. There are, in fact, 2 papers about to come out that will increase this to about 30 patients, and clearly many more patients are being done. One of the problems really with all of these publications is that there's not a huge amount of reporting of complications. There are, the classic ones being your pneumothorax, pleural collections, the placement of a chest tube, hemorrhage, fever, etc. But most of the papers, unfortunately, don't really talk about that, which is always a good technique when you're publishing a paper. With published abstracts, there's been 373 patients in the abstracts, and again, a woeful lack in the abstract review of the complications that have occurred. Having said that, RF ablation, certainly in our experience, is technically feasible. The patients, in fact, do remarkably well. We have now a cohort of 78 patients that we've treated over the last 4 years. We have follow-up ranging now up to 3 to 4 years. The real issue is, who are we going to apply RF ablation to? The one big group that we are interested in is in lung cancer for both local control as an alternative to radiation therapy. This is a technique that's under a lot of discussion, and in fact, the American College of Radiology Investigator Network is putting together a trial in the hope of comparing patients randomized either to stereotactic radiotherapy, which is now the competition for RF ablation, as a double-sided trial. But in fact, the real interest is in the role of the solitary pulmonary nodule. Is this a technique that can be used early on and not just in these salvage patients? Because you potentially, as we diagnose all these nodules and create very expensive algorithms, there is a research interest in whether this is a technique, because the smaller the lesion, the better the ablation. And as we are biopsying, and thanks to Yankelevitz here in New York, he's pushed the bar down to making us go for lesions at 6 millimeters. And so we've all tried to keep up with him, and that's what we're doing. If you're putting a needle into a 6 to 9 millimeter lesion and you confirm cancer at the time, and the case has no other evidence for metastatic disease, we believe that to be the case that you'd want to go there and then and ablate the lesion. That's the research interest, and that's where the direction is going. And the new trial being put together, in fact, will focus on that spectrum of lung cancer. clearly controversial, and I don't mean to leave you with the impression that that's the treatment algorithm at UCLA for solitary pulmonary nodules, but it's certainly one of our research pathways. More importantly, though, is in the management of metastatic lesions. And here, the two lesions that have really come into focus over the last 18 months is colon cancer and sarcoma. The colon cancer story, of course, is a very interesting story. Our colleagues in GI started ablating these lesions 5 to 10 years ago and have done a wonderful job. And these patients get through the liver metastases, but now they're popping up everywhere else. And one of the key places they're popping up is in the lung. And so it's felt that it's very important that that cohort of cases, once the liver lesions are treated, they appear over time to then develop lung lesions. And so we've just started a trial with our GI team in metastatic colon. But a very other interesting cohort is the sarcoma patient. These are very difficult patients, as you know. These tumors can grow and grow out of control, and it's a horrible tumor to have in your chest that engulfs the whole thorax. And surgical resection is very frustrating because you resect and then they just grow around the suture line. And it is felt that maybe early RF ablation of these metastases, when they're well less than 3 to 4 centimeters, might be a very effective technique. And certainly that's a study that we've just launched with our sarcoma clinic. So thank you very much. I hope that's given you a little overview of RF ablation in the thorax. Thank you.